Hey everyone, Dr. Rob here. I want to take a moment to spotlight my sponsors, Professional Co-op, empowering clinicians with premium access to top-tier lab services at a fraction of the cost. Since 2001, Professional Co-op has redefined what efficient, patient-centered support should look like. No hidden fees, no minimums, and you only pay for completed tests. It's lab access made simple, transparent, and affordable. Trusted by licensed healthcare professionals across the country, Professional Co-op is your strategic partner in delivering high-quality care. Discover more at www.professionalco-op.com. A quick shout out to my other sponsor, Functional Medicine University, one of the top online programs for learning functional medicine. Founded by Dr. Ron Grisanti, FMU has trained thousands of healthcare professionals in over 50 states and over 68 countries. It's completely online, self-paced, and CE approved for a wide range of clinicians, MDs, DCs, NDs, PAs, and more. At the end of the program, you earn your certified functional medicine practitioner credential, something that's truly elevated my clinical approach. If you're ready to level up your practice with evidence-based root cause care, FMU is the place to start. Check them out at functionalmedicineuniversity.com. Hey everybody, Dr. Rob Silverman here, Proven Health Alternatives. I have a superstar in the world of functional medicine, a two-time best-selling author, Dr. Felice Gersh. Dr. Gersh, how are you doing today?
Just great. I'm so happy to join you here for your podcast.
We're really happy to have you. I know you're going to lay what we call those knowledge bombs and share some really implementable ideas. So I've got a couple of notes here. Various studies have shown that menopause can raise a woman's risk for several health conditions, including sleep disorders and cardiovascular issues. Almost all women from the ages of 45 to 55 will experience menopause. Lastly, research estimates that there's more than 1 billion women globally which will be in menopause in 2025. What is going on?
Well, it turns out, and this I figured out decades ago as an obstetrician during my heyday of doing deliveries for 25 years, thousands of babies, it became quite apparent to me that the prime directive of life, whether you want to have kids or not, is your choice, but the prime directive of life is the creation of new life. And to that end, you need to have a healthy body. You need a healthy cardiovascular system, neurological system, genitourinary system, musculoskeletal system. Every organ system has to be optimally functioning for successful reproduction. In humans, in order to be successful, you have to be fertile, you have to conceive, you have to have an uncomplicated pregnancy,
Right.
deliver, nurse the baby, and then do it several times over and
Mm.
raise each child to his or her sexual maturity. So you have to be really healthy to have the species persist and survive. To that end, estradiol, the estrogen made by the ovaries, I consider like the hormonal glue that keeps all the organ systems working in the same time zone, in optimal state of being. And when we go through menopause, we lose our ovarian. It's so simple. We lose our ovarian production of estradiol and its sidekick, progesterone. And so every organ system, these hormones have receptors throughout the body on every organ system. We become insufficiently provided with these vital life hormones. I never call them sex hormones anymore, they're life hormones. And so every organ system will suffer a serious metabolic hit. And unfortunately, every female, 100%, no matter what continent, no matter what ethnicity, every female will experience the process of menopause, which is actually a word that is unfortunate because it makes it sound like it's all about periods when it's all about the ovaries, about aging of the ovaries, ovarian senescence. And we have to, as females, go through menopause, not just because nature dictated it, but because if that didn't happen, we would all die because fertility becomes really dangerous as you age.
Mm.
As an obstetrician, a woman who's 35 or older is considered elderly and starting to have high risk factors. So if women stayed fertile throughout their, highly fertile throughout their late 30s, 40s, 50s, 60s, they would all die in pregnancy and childbirth, the babies would die. I mean, it would be,
Mm.
basically suicide to all females at that point. That's why males can be fertile forever because they don't have to go through pregnancy. Females have to stop. But with that hard stop, which could be anywhere typically average, like you mentioned, 45 to 55, but some are earlier, some are later. But it's going to be universal, and every woman will suffer with some issues. It's not just if, it's how bad, because every woman is unique and different and comes from a different point of health and so on, and genetics. But every woman will suffer a serious metabolic shift as her hormones decline. And this wisdom, this like foundational understanding of women's physiology and what menopause is, was lost, really lost for the last 23 years in the conventional medical world because of the Women's Health Initiative and the mistaken interpretation of the study. And so, the important thing is to resurrect this knowledge base of what is really happening to women so we can be proactive instead of just reactive as issues are being developed within the female body.
Love the idea of proactive versus reactive as we'll get to the wheel of fortune of functional medicine. But you said estradiol. A lot of people may be confused. What is estradiol and how does that differ then from estrogen?
Oh, that is such a really important point because, and we can talk also a little bit about progesterone.
Mm.
So, estrogen is not a hormone, just like fats are different. B vitamins are different. They're like families. Estrogen is a family of steroid hormones in the estrogen family. And in humans, there are four estrogens that can naturally occur, three in adults and one in the fetus, coming from the fetal liver, and that's estradiol. But the other three that are in the adult female, and they're in males too, but we'll leave males out of this for now, they have much smaller amounts, would be the estradiol, known as E2, the big letter, just like
Mhm.
B vitamins. There's a letter and a number, just like there is B1, 2, 3, 4, 5, all the way up, to 12. And they have the big letter, the number, and then they have a name. The same thing for estrogens. There's E1, that's estrone. And then there's E2, that's estradiol, E3, estriol, E4, estetrol. And they have different strengths in terms of how they bind. They also have different effects on estrogen receptors. So they basically have different effects in the body that can be
Great.
quite dynamically different. And E2 estradiol is the estrogen produced by ovaries. It's the dominant estrogen of reproductive aged women, and only estradiol binds to all the estrogen receptors in a balanced, coordinated way. And the other estrogens are not evil. They're supposed to be there, but they're not supposed to be the dominant one
Mm.
during non-pregnancy when estriol is the dominant one. But pregnancy is a whole unique state of being, which we don't want to recreate unless you're actually pregnant, because there are a lot of potential problems with. That's why pregnancy is a unique time, a very stressful time for women. That's why it's known as the ultimate stress test for reproductive
Mm.
women. So estriol is a critically important estrogen, estrone as well, but they're not supposed to be the dominant one in women who are like reproductive aged, and they're not optimal to be the dominant one at any particular point, except if you're dealing with estriol and you're dealing with pregnancy. So anyway, it's really important to understand this. And then we have other estrogens that are man-made, but they're still called estrogen. Like the usual estrogen that's in birth control pills is EE, ethinyl estradiol. And so it's a different molecule, but it can bind to estrogen receptors, but not in an identical way to estradiol. And then there are what are called xenoestrogens. These
Mm.
are the ones that are the pollutants, the endocrine disruptors that are in our environment, like things like BPA, bisphenol A, phthalates, even like metalloestrogens like mercury. They actually can bind to estrogen receptors. So there are numerous endocrine disruptors, and some of them have actually become pharmaceuticals. They actually are endocrine disruptors. Actually, ethynyl estradiol, if you went to toxicology.gov on the NIH website, it's listed as an endocrine disruptor. So
Wow.
yeah, so they're estrogens, but they're not natural estrogens. They have different effects. And we need to understand it's so important because even in like really high end respected medical journals, they often use the word estrogen incorrectly when they're referring to one thing, but it's really another thing, or they group them all together like they're all the same. So my analogy would be like fats. So there's trans fat. Now, most people know manufactured trans fat is very bad for people. But then there are monounsaturated fats, like from olives, and then there's omega-3 fatty acids, omega-6 fatty acids, and they all have, and then there's saturated fats. I mean, they have different effects. They're made of different fatty acids, and they're not all the same. And if you do a study with trans fat, and the conclusion is all fats are evil. Stay away from fats. And I bring up fats because I used to defend fat all the time,
You were
because
right.
you too, I'm sure we had to
Yeah,
defend
you
fat.
were right. No doubt about it.
Yeah. But now, I mean, so if you do a study with trans fat, but your conclusion is all fats are evil, I mean, that's a big problem because guess what? Fats are essential to life, so that's what happened with that Women's Health Initiative study.
Mm.
They used chemicals and hormones that would never exist in a normal female in a very different way, and they had some adverse effects. But the problem with the study was the study studied what was in the study, but they made generalizations to all hormones. That's like a criminal offense, really, in medical science and research to over expand your conclusions to things that you didn't even study. And that would apply, of course, if you did another study, and there were some other studies to follow where they used what I would consider the wrong doses, or additionally the wrong forms, like an oral form of estrogen, which has a different effect than a transdermal form. So there's been a lot of problems in the research around hormones and menopause. And my goal is to try to start getting some appropriate studies because we can never get the conventional medical world to buy into anything without clinical studies. There's a ton of science. We know the science, but if you don't have clinical studies, the medical societies will never change their position papers on what they recommend, which they have not, because they'll say, but where are the clinical studies? And it's like, well, nobody's funding them. Well, then we're not going to change our position. But look at the science. Then they don't want to buy into the science. So it's like, it's really frustrating as a doctor who's taking care of women for decades and understands menopause and what it does to the female body, and that it doesn't matter to me that it's natural. It has to happen, but it's not naturally beneficial. And
Mm.
so, everything that's natural doesn't mean it's going to provide benefits. So, it's about time and things, the tide is changing, and menopause is now being recognized as a big hit, metabolic shift, and so on to women's health, and how many organ systems are involved since these hormones have receptors in every organ system. But even when that becomes established as the norm that menopause should be treated, then we have a whole new layer of problem, which is, so what are you going to do about it? Like, how are you
Mm.
going to give the hormones? And that's the next stage, is first recognizing menopause is a condition of women's lives that really should be treated. And then the next is, so what are you going to do about it? How are you going to give hormones? And well, are hormones sufficient? No, you still got to do all the lifestyle stuff. At every stage of life, you've got to incorporate all the lifestyle elements. And because hormones are, I call them necessary, foundational, but not sufficient. But, so there's so many layers of what to do about perimenopause and menopause. But at least now people are more open-minded in general. The dialogue is now happening. So that makes me at least smile.
There's a lot to unbox there. That's great stuff. So, loss of estradiol, increased visceral fat. increased insulin resistance, altered lipid metabolism, weight gain, increased risk of type 2 diabetes, metabolic disorders. I don't want to go through female menopause. So there's two big questions that probably resonate from the people listening to you. Number one is what blood tests, what numbers should I look for from a practitioner? Are the regular Western medicine practitioners taking them? And number two, how do I get rid of these endocrine disruptors?
Wow, that is a lot too. And one of the things that you said, and I just want to jump to again, was like you talked about like fat tissue and fat
Mhm.
deposition. And that is really something that women notice. They notice that even when they try to do everything right, they're still eating the same healthy diet and they're exercising, maybe doing even more. They find that their waistline is disappearing, they're getting belly fat. And
Mm.
that is just really like the epitome of obviousness of what estradiol does in the body, that it does control everything about adipose tissue, the adipokines, the hormones. Fat tissue is an endocrine organ. It makes leptin, adiponectin. These are like vital hormones involving energy regulation, appetite regulation. These are like critical hormones that are regulated by estradiol that many people don't realize. And without estradiol, things become dysregulated, and you end up with this inflammatory visceral fat. And the other thing that everyone should know is that there are these little organelles, they may have heard of them, called mitochondria,
Mm.
that are the energy producers, and they do more than just produce energy. That's like a critical function in itself, but they control the cell cycle. They help to decide like which cell is doomed, because it's old, it's senescent, and it should die. Because if old cells don't commit cell suicide, apoptosis, and die, they live on to create inflammation, potentially turn into cancer cells. And sometimes they're called zombie cells, these like really yucky old senescent cells. All of that is controlled by the mitochondria, and the mitochondria are hugely modulated by estradiol. So when you lose your estradiol, you lose control of the cell cycle when cells should die. You also cannot properly create energy. You can't burn glucose. You can't burn fat properly. So you can see how all of these metabolic
Mm.
processes that you mentioned, like insulin resistance, the glucose transport system relies on estradiol. So all of these things are like really critically important, and related to the fact that pregnancy, for example, it's critically important that you have the optimal energy state. So you have the intake of energy known as eating, right, to match the needed energy expenditures. So all of that is modulated by estradiol. So, these are like just huge, huge things that everyone should realize, that these transformational systems involving our energy, and that's what metabolism is. When people talk about your
Great
metabolism is
point.
changing, and the utilization, production, distribution, storage of energy, all of that is vital for life and regulated by estradiol. And the immune system as well. After menopause, women become systemically inflamed because we have more of these zombie cells, but each of the each of the immune cells of the body has estrogen receptors. And without estrogen, their default is to become more pro-inflammatory. And these different pathways, many pathways in the body have two arms, like the pro and the anti-inflammatory.
Mhm.
Without estradiol, by default, they go into the pro-inflammatory. So that's just a smidgy more background on it. And then let's get back into your questions.
No, that was great. So, highlight point, mitochondria, powerhouse of the cell. They also have an immense impact on immunity. I love the fact that you highlighted. I mean, that's an overarching theme, the cell cycles, autophagy, mitophagy. We
Oh,
in the
that's
world
right.
of functional medicine, if these cells don't die, they spew, those zombie cells are spewing out inflammatory things. It's like the Boris Karloff monster. It's like, I forget her name in The Exorcist, Linda Blair, just
Yes.
spewing out all sorts of things. Sorry for being graphic. And I
No,
think
I
that's
love I
a,
love images, so that's great.
I think that's a salient point. And, I sit here and every time I have a female patient coming in from 40 to 55 who's looking at me, as a male, you wouldn't understand just from your description. I understand better. But what blood markers should they be taking? And how
Yeah.
old, that kind of stuff? Can you guide them
So,
because they come in with very
well,
rudimentary levels?
there is for perimenopause, there is no like absolute test. Like you are clearly in perimenopause, but there are things that can be clues. Number one, well, this is clinical evidence, not a test, but if the menstrual cycle is changing, often what happens is the cycles get shorter. So maybe there was a 28, 29-day cycle, it drops to 26, 25 days. That's what's shortening is the luteal phase, the time after ovulation gets shorter. And that is also coinciding with reproductive decline, right? So we know
Mm.
fertility goes down as well, and that is often manifested in an inadequate or a short luteal phase. In addition, there are many symptoms that women may experience years before the actual official menopause, which is an artificially defined term, right? 12 months without any bleeding. That's actually late in the process, not early in the process of ovarian senescence or aging. So women may notice symptoms that, and they're often unfortunately just kind of brushed off by doctors. It's and this is another shocking thing. Over 25% of women in their 40s are started new starts on antidepressants in their
Mm.
40s, and they're perimenopause because mood there's receptors all over the brain for estradiol, progesterone, and as these hormones are declining, the neurons that are involved in making the neurotransmitters like serotonin, they're
Mm.
serotonin neurons. They depend on estradiol for the production and receptor function of serotonin. And from serotonin comes melatonin, which of course is important for many things, including sleep. So many women, years before, like 5 years, even more than that, before the final menstrual period, start having sleep disorders and maybe start having sleep apnea. I order a lot of sleep studies. We start with the home sleep study because they have disordered breathing during sleep and sleep apnea, and they will have mood swings. That's why they end up, so many of them, on antidepressants and tranquilizers and so on. And they'll notice the weight change, like you mentioned, like visceral fat. They'll sometimes start having vaginal dryness or overactive bladder or incontinence symptoms. So they'll start having different forms of incontinence. And every woman looks in the mirror, at least from time to time, and they notice skin wrinkling because a lot of collagen is lost all over the body, in joints, in bone, in the skin, and they see facial aging. I mean, the plastic surgeons start seeing this influx of all these women showing up in their
Mm.
40s and sometimes late 30s because many women are already going into menopause in their early 40s. So the precursor is the 30s, right? So they're having issues already. And so there are many just clinical signs that may be happening: change in libido, change in energy. So there's a lot of that is going on. And silent things are happening, of course, as well, that need to be monitored. Blood pressure can start rising. A blood pressure cuff is a really good thing to have because that's a sign not of early, but actually late vascular disease by the time you actually have, pre-hypertension and hypertension. Cholesterol goes up. So it turns out that cholesterol, the enzyme that, for example, that statins are partially blocking, HMG CoA reductase, that enzyme is modulated by estradiol. So basically, 100% of women will have increase in cholesterol production from their liver because of dysregulation of this enzyme as their estradiol levels start to drop. And this can occur, like I said, a few years before that final menstrual period. In addition, there are what are called LDL receptors on the liver that help to pull cholesterol that's circulating out from the blood back into the liver for either disposal or recycling. The LDL receptors rely on estradiol. and you get more inflammation that leads to oxidative stress, reactive oxygen species that can lead to oxidation of cholesterol. We call it oxidized LDL. And the enzyme that helps to block the oxidation, or like the equivalent of rusting of cholesterol, is peroxidase 1, known as PON1. That enzyme has a modulation effect by estradiol. So there are all these things happening to the lipid system. And then because you get more insulin resistance, that will often translate into higher
Right.
triglyceride production as well, which is often a reflection of insulin resistance. So you definitely want to get a lipid profile. You want to get a high-end lipid profile, whether you like to get lipid particle sizes. I like to get the apolipoproteins, A1 and B. So it shows me like, okay, we don't want to just know total cholesterol. We want to know, is it inbound or outbound from the liver? So that's really important, like, because many women, and that's another thing that's not recognized, HDL, which some people call good cholesterol, but it really isn't. It's just cholesterol. It's just a carrier protein for cholesterol. And a piece of that is called apolipoprotein A1, and
Mm.
also known as reverse cholesterol. So it's the particle, or like envelope, that carries cholesterol back to the liver. And that is actually modulated by genetics and estradiol.
Mm.
So it's like, it's like every time I research anything, it's like, yep, estradiol's involved. So, you want to get all of these lipid profiles. Now, here's another interesting thing. There are receptors on the thyroid gland for estradiol, and the receptors for thyroid require, for optimal function, estradiol. So many women will develop like low thyroid, hypothyroidism, when they are transitioning into menopause. And even if they have so-called normal or in the reference range thyroid levels, they may have the symptoms of hypothyroidism because their thyroid receptors, as the estrogen production goes down from the ovary, their thyroid receptors are less functional, kind of like similar to like insulin resistance. We have thyroid receptor resistance. So you need to have the receptor working to receive the hormone for the ultimate effect within the tissues. And so many women are also brushed off because they read Dr. Google and they have all the
Mm.
symptoms of hypothyroidism, but their lab tests don't show it because the receptors are not working optimally. But you want to get that. And then many women will develop Hashimoto's as well, because when you don't have enough estradiol, the gut microbiome shifts to a dysbiotic state. You have abnormal gut microbial population because that relies on estradiol. It's like a really amazing synergy between the hormones, the autonomic nervous system, which has the vagus nerve, which is the part of the parasympathetic, which should be the baseline. They call it rest and digest. It's when things are calm and really good. The predominant neurotransmitter for the vagus nerve is acetylcholine, which requires estradiol for proper production and function. So after and in the transition into menopause, women become more sympathetic dominant. That's S as in stress. That's the stress part of the autonomic nervous system that sometimes people call, fight or flight. It's should only be induced, the sympathetic part, when you have trauma, you have injury, you have pathogens and infection. It shouldn't be the normal state. But what happens as you transition is you have vagus nerve going down in terms of the vagal tone. You have less parasympathetic, more sympathetic. So women are more stressed, they have more anxiety, and they have more palpitations. A lot of that
Mm.
happens because of the sympathetic nervous system being overactivated, and they don't. And the vagus nerve, the autonomic nervous system, controls everything in the body we don't think about, which includes gut motility, the peristalsis of the gut. So as women are transitioning into menopause, they have more acid reflux, more GERD. Like before menopause, women have much less acid reflux or GERD compared to men, but with the onset of menopause, women surpass men in GERD, and they will then have gut problems, gut motility problems, which also will affect the gut microbiome. So women, as they transition into menopause, will get leaky gut, impaired gut barrier. And that causes inflammation also because you have the toxins coming into the body. But as well, when you have the microbes from the gut coming into the body, it's tantamount to a chronic infection. And
Right.
the immune system, which resides largely around the gut, ultimately starts reacting to the passage of these microbes into the body, and they will create antibodies against these microbes coming in. And as a chronic infection, over time, there is a process that can occur called molecular mimicry,
Mm.
where our own RNA and DNA, the nucleotides that make up all life forms, are similar, whether it's a bacteria or us. And it's like mistaken identity. And we start making antibodies against ourselves, which is autoimmunity, which can lead to Hashimoto's, autoimmune thyroid, and rheumatoid arthritis, which is predominantly seen in postmenopausal women. So we know, so you have the change in the gut, the immune system, the autoimmunity. So we need to test for these things. Many women will have aches and pains, and they'll have joint pain. We need to look for things like autoimmunity, rheumatoid arthritis. We need to test for Hashimoto's. We need to test for, the different antibodies that are involved in hypothyroidism from autoimmunity. So those are important. And because I mentioned like inflammation goes up, this what they termed inflammaging, we want to test inflammatory markers. So of course we want to get high sensitivity C-reactive protein, we want to test homocysteine, and I like to test ADMA, which is a surrogate marker for nitric oxide, a
Mm.
critical gas that maintains vascular health, prevents platelets from grouping together, aggregating, creating, inappropriate blood clotting. And we need to have this nitric oxide, but we can't measure it directly, but we can measure a surrogate called ADMA. And when ADMA is high, it's a reflection of low nitric oxide. So I like to measure that. And sometimes the enzymes like LPPLA2, which is an enzyme made by white blood cells, which if high is an indicator that there is likely inflammatory plaque in the artery wall. And this is like a marker for that. I also like to get ultrasounds of my patients in my office. We have the ability to test, to look at the thickness of the intima, the lining of the
Mhm.
arteries, and plaque formation in the carotids, in the leg arteries, which are an incredible mirror of the coronary arteries, the heart arteries, and looking at the aorta. So that's not a lab test, but it's, an imaging test that's also extremely useful. And then because we have changes in the gut, we're going to have changes in digestion and absorption of nutrients, like these critical micronutrients. So minerals and vitamin levels systemically can go down. And of course, they can have consequences throughout the body and every organ system. The micronutrients are the building blocks of all of our coenzymes and our cofactors. You got to have them. And so I like to measure a lot of the nutrients as well.
Mm.
So, I love data. So, I love to
Oh,
get
yeah.
all of these different lab tests. So, because once again, you can't monitor if you never measure. And so lab testing is a critical part of the workup. And then in terms of the hormones, one of the things that you can test is a day three of the menstrual cycle. The first day of bleeding is called day one. So then day three, you get an FSH, follicle stimulating hormone. If that FSH number is over 10, we use that for fertility prediction. Like that would be a sign of, unfortunately, for people who want to conceive, low fertility. If their day three FSH is over 10, it's a sign of old eggs. That's what happens to us. And they're less likely to get fertilized and turn into a healthy embryo and implant. So if a woman has a day three FSH and it's over 10, that would be indicative of aging ovaries. Okay. It doesn't give us a timeline for when the last period will happen, but it does tell us that the ovaries are in the process of, you know, aging.
Mm.
So that can be helpful. You can also get menstrual mapping, which is looking at urine metabolites
Wow.
of hormones. And then you collect multiple samples with dried urine throughout a menstrual cycle, and then it gets plotted on a graph, and you see, okay, for that cycle, how was your estrogen? How was your progesterone, your luteinizing hormone? And what will show often, even for women who have cycles, they could even be 28-day cycles, but everything is kind of miniaturized. Whereas we'll say the normal estrogen level at that point should be here on the menstrual mapping, it's like half that. It's like literally half or less. So it's like a miniaturized version. The hormones are being produced, there's a cycle, but nothing is the same. And that's why, of course, it reflects in declining fertility. And those are women that can really benefit from, I call it hormonal supplementation during
Mm.
perimenopause, because we know women lose a lot of bone in the 5 years preceding the last period. We know that their vascular system is degrading and their brain is often changing. Women have word finding, especially nouns. They can remember adverbs and adjectives, but they can't remember verbs. I mean, I'm getting it wrong. They can't remember nouns, okay? So they can't remember the names of things, but they can describe it. So it's like playing charades. So the bottom line is that, there are loads of things that we should be looking at and testing, and then responding by giving hormones to perimenopausal women as a safety net, as a supplement to declining hormone levels. This idea that you wait until you're at rock bottom, nobody does that with hypothyroidism. If you have hypothyroidism, nobody tests and says, well, your thyroid is quite low, but it's not zero. Let's wait to see how low it will go before we
Mm.
treat you. That's like the attitude for treating like menopause. It's like, well, you're still perimenopausal. Let's just wait until you have no hormones and then we'll treat you. That is not the right approach. That is being reactive. We want to be, like we talked about, proactive. So we want to start
Absolutely.
the hormones when they're on the decline, not when they're already reached rock bottom.
So, a couple of quick points, and then, of course, a follow-up question. Clearly, the wanted sign is elevated levels of estradiol because when it goes down, this whole cascade, this deleterious cascade starts off. Interesting. You definitely signaled and emphasized the idea that the body's all interconnected. One thing goes, it's a chain of events, those dominoes all fall. I agree with you. That's, for me, one of the tenets of the idea that we talk about in functional medicine. And functional medicine to me is not root cause resolution or just root cause or root causes. It's this whole idea of linking the chains and using more of a liquefied thinking and understanding as opposed to just being crystallized. Thirdly, this seems inevitable. What do I do with my wife who's going to be 53 and is going through the transitional period? Give me three quick, easy takeaways to make her life easy, hence happy wife, happy life.
From a hormone position, there's no woman that is 53 and is not at least perimenopausal.
Oh,
Okay.
without question.
Yeah, 100%. You'd have to be an alien. So we know
Mm,
she's a human. So, yes. So she needs hormones. Now, this brings up the how to give hormones. So, just as a just quick word on that,
mm,
we don't want to create a regimen of hormones that never exists in a human being. It's like the biggest failed experiment of we're smarter than nature was, of course, ultra processed food. We're going to make
mm,
food that never spoils. We're going to give hormone regimens where a woman never has to bleed. Bad idea. We have to accept how we were created. One of the beautiful things that estradiol does is, among many other beautiful things, is it creates growth factors.
mm.
Now, growth factors in the brain are things like brain-derived neurotrophic factor, nerve growth factor. You have VEGF, you have vascular endothelial growth factor, so you create new blood vessels, tissue growth factors. You need these growth factors. That's how you restore, rejuvenate, replace cells, right, from our stem cell pool. And you grow bone, replace dead bone, grow and nurture neurons, and all of this. This requires growth factors. Now, when you go on hormones, you're going to rejuvenate every organ system because blood goes to every organ. So the hormones go everywhere. So when you give systemic hormones, you're going to literally rejuvenate every organ system. Now, here's the catch. You're going to rejuvenate your uterus. If you have a uterus, most women still do. And rejuvenating the uterus means you're going to grow with growth factors the uterine lining. And
Mm,
here's a truism: if you grow it, you must shed it. You can't just keep growing. So there are
right.
many hormone regimens now that are being promoted like profusely, where they give a tiny dose of estradiol combined with nightly oral progesterone for the purpose of suppressing estrogen's growth factors, because progesterone is like the yin yang kind of thing. They're
Mm,
synergistic and they're sometimes antagonistic. It's a beautiful dance of these hormones. And there's rhythm and there's method to this madness, of the cyclic hormones and the rhythm and everything. And progesterone down regulates estrogen receptors. So the theory behind giving these kinds of hormone regimens is we will not let the woman bleed, but we're going to suppress night sweats and hot flashes, which can happen because it takes a very tiny amount of estradiol to suppress night sweats and hot flashes, but it takes much more to create growth factors and to do other things like nitric oxide production. So you'll get something, but it depends on what your end game is. What do you want to do? If your goal is just suppression of some symptoms, which is not invaluable, it is important, then that's okay. But if your long term goal is healthy longevity, healthy aging, then that's not the ticket to it. And you have to accept that this is how females evolved. And if you want to get all the benefits of growth factors and all the other issues that are so maintained and modulated by estradiol, everything is dose related. Like you would never say, I want you to exercise. Why don't you do 5 minutes a month? Because there's a dose relationship to outcome. That's true for hormones as well. So, this idea of super low dose estradiol combined with nightly oral progesterone is really bad and there's even
mm.
some data that it may long term even increase dementia because you're
Wow.
down regulating the benefits in the brain of the estradiol by continually giving the progesterone. And when you give oral progesterone, it's metabolized in the liver 80 to 90% into metabolites, into other stuff. So you don't even get adequate amounts of progesterone, really, but you get a lot of other stuff. And the other stuff that's made by the liver is good. It's predominantly allopregnanolone, but too much of a good thing is a bad thing. And it overwhelms the GABA receptors. It's a GABA receptor agonist. It stimulates GABA, which is the inhibitory neurotransmitter that's sedating. It puts you to sleep, but it also makes it harder to make memories. It reduces memory production. So
Mm,
there's some concern about in rats. Now, this is rat data. I can't help that we don't have long-term human data
right.
because nobody's doing the studies. But when you give chronically high doses, which is what you get if you take oral progesterone every night, if of allopregnanolone, you induce dementia in the rats. And there's
Wow.
some data that it will impair memory formation in humans. So it's like that doesn't make any sense. None of these regimens make sense. So for your wife, she should go on a regimen that is aligned with nature's regimens. Like just think of it as these crazy other regimens that are being created are like ultra processed food. They're designed to do something that should not happen, like food should never spoil or that women should never bleed. We have to just get over that. You can't have these regimens and ridiculous doses and administrative protocols. That's not going to help. The next thing is to recognize that staying optimally healthy in the menopausal years, which could be half of a woman's life, is hard work because you no matter how we give hormones, it's not like being 21 years old and having 21-year-old ovaries. We're doing the best we can, but it's not the same. It's similar, but it's definitely not the same. So you have to work really hard. Every woman should get on her exercise program, eat tons of plants, get all the fiber that which is so critical. You have to restore the gut microbiome and gut integrity. So you have to work hugely on diet with eating fermented foods, lots of fiber containing foods, polyphenols, these magical ingredients, the phytoestrogens, I call it nature's gifts to women. all these magical phytoestrogens that are in plants and all kinds of plants, in nuts and seeds, as well as vegetables and fruits. And don't overdo the animal, just a little bit, like 3, 4 ounces a day. You can get plenty of protein from legumes, so you don't want to overdo the animal because the gut microbiome makes other bad products, like TMAO. We don't need that. We want to make
Right.
sure that we have a good, healthy gut. We want to work on sleep hygiene, doing everything we can. Look at the sunset, dim the lights so we have all the right sleep hygiene so that we can get restorative sleep. Get it, like I mentioned, get into a really good exercise program, and more resistance training seems to be the ticket to maintaining muscle mass, which muscle is another whole topic for another day.
Oh,
Muscle
wow.
is
Yeah.
underappreciated as an
Yes.
endocrine organ with the myokines, and what it does, and it's the biggest burner of glucose and fat. You're going to be diabetic if you have no muscle, because what's going to burn your glucose, right? And of course, frailty is more predictive of mortality than hypertension. So we don't want to become frail people, and bones, so you want to make sure you get adequate protein. You want to make sure you have all those essential minerals to maintain bone properly. So, you got to do every lifestyle thing. You got to, of course, avoid as much as humanly possible the endocrine disruptors, the chemicals, the plastics, the flame retardants, the PCBs, and all the other, air pollution. Get water filters, air filters. These are like really important things to do. And work on stress. Women's autonomic nervous systems become dysregulated. They become in a more stress mode. We don't want to put everyone on SSRIs and tranquilizers. We want to work with things that increase vagal tone, whether it's laughter yoga, nature walks, meditation of different types, massages, acupuncture. All these things increase the output of the vagus nerve. We have to increase vagal tone. So, and one of my favorites is honestly laughing. So,
Mm.
whoever coined that, seems like a cliche, laughter is the best medicine, was not stupid. They were smart,
Good.
laughter actually, and then breath work, yoga, all these things maintain flexibility. All this is wonderful. So the bottom line for your wife is get on proper hormones
Mhm.
and just work really hard with all of the lifestyle issues that, of course, most people are now aware of, but they're not always doing them. And then maintain purpose and love in life, because and socialization, we know that loneliness is a big cause of death. Maintaining friendships and purpose in life, no matter how old you get. And that's what they always find in the so-called blue zones, is that at every age, in the most elderly part of the population, they are part of the family. They have purpose. They have a sense of belonging. They're not outcasts. They're not, put in a room and, watching television all day. So, not that that's your wife, but this happens to people when they become seniors and they get lonely and isolated. And that is a very high, cause of cardiac death. So, maintaining purpose, love, proper lifestyle, and proper hormones aligned with how women's hormones are designed to be in their body, that's the ticket to healthy longevity.
Outstanding. So we're at that point where we do what I call rapid fire, New York style. You said you were originally born in New York, so we're going to dig into those roots. Real short, pithy answers if you can. Detox for a woman going through menopause, yes or no?
Absolutely.
Love it. Sulforaphane, good, yes or no?
Yes, but I do emphasize adequate intake of cruciferous vegetables. We don't know long-term use of things like sulforaphane, so I usually only advocate for maybe 3 months at a time, just because we don't have data. But I always advocate for eating cruciferous vegetables.
What do you do if estrogen is going to get recycled after phase one and phase two of the liver? Yes, that's a geeky question. What do you recommend?
Oh, well, you have to always work on liver gut health. There's no question. You want to maintain that special unit of the microbiome called the estrobolome. So, of course, detoxification, that was my first answer, yes. And all chemicals, all molecules in the body need to be detoxified, and that includes estrogen. So we know fatty liver increases, gut dysbiosis increases in menopause. So it gets back to diet, and better diet, and then working on reducing stress so that you don't have that sympathetic nervous system, which damages your gut motility and all and the whole system at play. So absolutely, we need to have good detoxification for everything, including estrogen.
Hot flashes, what causes them?
Dysregulation of the autonomic nervous system, and in the hypothalamus of the brain, the thermoregulatory center there becomes dysregulated, and this is a big interconnection between the brain and the autonomic nervous system.
It is 66.6 degrees in my room, and my hypothetical wife, I won't say my wife, comes in and goes, "Is it hot?" What do I do? Help me, doc.
Tell her, no, that's you, not the temperature. That's the ambient temperature is fine. Your endogenous temperature is not. Let's get you on some hormones. But there are other things as well that can be given.
Mm.
Phytoestrogen supplements. My favorite is the rhubarb. The Siberian rhubarb
Mhm.
has some companies have created product from that. There's evidence that if you eat a cup, this came out from Neil Bernard, who's a vegan cardiologist who did a study where you eat like a cup of soybeans every day, and in 12 weeks your hot flashes are pretty much 100% resolved. That's from the isoflavones, the phytoestrogens that are in there. So get more plant-based diet, take supplements that have the phytoestrogens, and that can be beneficial in the both the short and the long run. And get
Here's
her a fan.
Get her a fan. She's got one that she walks around with. It's really
That's
cute.
exactly.
We sit in the restaurant, she's got the fan. Um, Supplements that'll help menopause. I'll hit you with a few. Vitamin D.
Oh, well, for everyone, including menopause, yes. I usually go for a level of about 50.
Okay, I go 60 to 80, but we can talk
Yeah,
about
I
it.
mean,
We're in a
I don't
ballpark.
go, I don't go 100, but yeah.
Right, over 100, I get a little sketchy on. Magnesium in which form?
Well, magnesium for sure. Almost everyone seems to be insufficient. So if they're constipated, which happens a lot because of this regulation of the motility, the autonomic nervous system, then I usually say mag citrate because that will have less absorption, but will have more gut benefit. If they don't have that, then I usually go with glycinate. I mean, I can go with 3 and 8, but usually I just go with magnesium glycinate. It kind of is an all-purpose good magnesium.
All great forms. Omega-3 fatty acids.
Yes, I usually recommend a gram a day. I don't do the high dose. There's like all these crazy questionable studies. Like if you go really high dose, like 4 grams, 5 grams, can
Mm.
you start, instituting somehow or other atrial fibrillation? So I try not to do mega dosing of things. So usually 1 gram of a good quality omega-3 product. And I know this is not typical. I happen to grow up with this as a food and I actually like it, but sardines, if you
Mm.
can eat frequently sardines, if you hate them, don't, but if you like them, I like to mix them in a salad. 1 can of sardines is a gram of omega-3. You get lots of calcium and you get a great source of protein. So if you actually like sardines, try to eat them frequently. You get a lot of natural source of protein, calcium, and omega-3.
Well, you definitely covered phytoestrogens. Red clover.
No, that actually is probably not one of the better ones, and it can actually be too much of an endocrine disruptor. It's
All
like
right.
sometimes you get too much of a good thing is a bad thing. So probably not red clover.
How do you feel about the peptides for menopausal women? Both something like a BPC 157, which is vastly different than the GLP-1 peptides.
Well, I don't use peptides. I think that there will be a place for them. I
Mhm.
think it's premature to be using them. We mostly have rat data, and a lot of them are, not all of them, like you mentioned, but a lot of them are injectables. We don't really know the quality. I find it a little bit frightening. I think that there will be more research on them. There will be a place for them for specific treatments as opposed to healthy longevity. I think trying to micromanage, when you know what peptides are signaling agents. They're short chain amino acids and they're, with certain like special features but they're signaling agents. And here's the complexity of it. You have like in your brain, you could have like oxytocin is considered a peptide. It's sort of on the border with a hormone, but or vasointestinal peptide. You have these different amounts, like in the brain, different parts of the brain will have different concentrations of a certain specific peptide. So if you give it as a shot, or no matter how you administer it, you're going to get you can't like say, okay, this part of the brain should have a lot and this part of the brain should have a little. The peripheral body should have less. I mean, this is how peptides are. They're like flash, like here you are, now you're gone. And they are different amounts in different parts of the body simultaneously. So I'm not thinking that I'm smart enough to micromanage the body on that level. So I'm sort of a macro manager as opposed to a micromanager. Peptides are more micromanaging. So I try to give the patient what, like, macronutrients, micronutrients, and foundational hormones. And by the way, many of these peptides, if you research them, they're modulated by estradiol. Like, it's
Oh,
amazing.
goodness.
All the mitochondrial peptides, they're all modulated by estradiol. So I have a simple kind of thinking. If I can make things normalized on a macro level, maybe I don't have to try to measure and monitor and regulate and manipulate things on a micro level. But I think there'll be a place for them. They're not illegal. They are rather mostly illegal in California, which is my state, which kind of takes them off my plate anyway, because they're just, California has a lot of regulations that not every state has. And so they're pretty much illegal in California. And so that's not really available for me anyway. All the injectable ones are illegal. So, but in terms of micromanaging, I think there'll be a place in specific situations. I don't think that time has come.
The idea of functional medicine, how does it facilitate an efficacious treatment plan and outcome?
To me, functional medicine is medicine. It shouldn't even have
Mm.
that label. It's understanding cell biology, how systems interact, like you mentioned. That's what medicine should be. Unfortunately, medicine sort of turned a corner back when Big Pharma kind of came into play, and they just created protocols like you have this problem, this symptom, give this drug, without even understanding, well, what's the mechanism? What are the side effects? Many drugs will block, say, an enzyme pathway, like statins. Like, so what are the consequences? What are the side effects? What are the pros? What are the cons? You want to look at the whole thing. That's what functional medicine is, like understanding the basics, the fundamentals of how is the body working? How are these systems aligning or intersecting? And how are these different, whether they're supplements, herbs, whether they're pharmaceuticals, what is the mechanism in the body? And how do they interact with other mechanisms and other drugs or herbs? If you don't understand that, you don't understand anything. And you're just becoming protocol driven without any foundational knowledge. So to me, functional medicine is what medicine should be, trying to really understand the mechanisms, the ways the body works, and then creating efficacious and safe ways to try to optimize health. Without that, you're just a robot.
Oh, I agree, indeed. So let's end with three things that everybody who listened can implement tomorrow to have a better day.
Eat more plants, walk more, and start doing some lifting, and go to bed no later than 11.
Love it. So it's all lifestyle. It's so
Well,
funny.
that's what you implement tomorrow.
Yeah, we all circle the wagon. I've had various practitioners, medical, personal trainers, the whole gamut. It all comes back to the same thing. What do you do? Are you putting some time in? There's no magic bullet, there's no magic pill. And honestly, you've answered so many deep questions with a quite of a real erudite type of description. It's been great, but at the end of the day, you still said lifestyle matters. I love it. Thanks for coming. I appreciate your time.